we are going to start today's online seminar. So, Sawadika to our friend in Thailand, Mikarapa, so our friend in Myanmar, Salamat Sien, our friend in Indonesia. So, good afternoon, ladies and gentlemen. Thanks to join us today's online seminar. I'm Nina, the Director of Overseas Medical Mission Center of Changhua Christian Hospital. I'm also the moderator of today's session. So first of all, I would like to express our sincere thanks for all of our participants from different countries and sectors. Special thanks to our speaker, Professor Chen, the Deputy Dean of Public Health College of National Taiwan University. So it is also my graduate university. I'm also graduate from the National Taiwan University. Before Professor Chen starts his talk, I would like to invite Ambassador Charles Lee, the representative of Taipei Economic Culture Office in Myanmar, to give opening remarks. Please, and Ambassador Lee.
Yes, good afternoon, everyone. Thank you so much, Dr. Gao, for arranging such an interesting web seminar for all of us. You know, many friends in Myanmar, just like me, are looking forward to this sharing from Professor Chen. And we know that the big data application in combating COVID-19 has been very successful in Taiwan. So friends in Myanmar are very eager to understand how we applied it. So I personally thank you so much, Professor Chen, for sparing this precious time to share with us. Thank you so much.
Thank you. Thank you, Ambassador Lee. The next, it's really our great honor to have Professor Surin with us. And he is the Vice President for Global Engagement and Faculty Development of Walailak University. And the university also the sister relationship with Changhua Christian Hospital. So I want to invite him to say a few words for all of our participants before the session. So Professor Surin, please.
Thank you.
Thank you.
Happy to be part of this. In fact, I've been, but I have this is a very interesting things that the Taiwan Christians very hard on this. That has been this obviously this is something that will very proud to be part of this, and again we can continue our relationship even thank you.
Thank you. Thank you, Professor. Even that's because the connection seems not very good. I hope that in the following, we still can invite you to give that feedback. So I'm going to invite Professor Chen to start his presentation. Professor Chen is an expert by using the complex statistical models to deal with very difficult issues. During the pandemic, he worked closely with government to monitor the development of the epidemic in Taiwan and globally. So today he is going to share the big data monitoring analysis and forecast about the COVID-19 pandemic. So Professor Chen, please.
Okay. First of all, I am very much grateful for Dr. Gao to invite me to attend these online meetings, and to also thanks everyone to give National Taiwan University College of Public Health, to extend our international relationship to Thai and to Indonesians. I mean, as a matter of fact, I have a long-term cooperation with Khon University in Thai and also Makassar University in Indonesia. So this is not first time to have such kind of the opportunity to have such chance of giving this lecture to everyone, and also our director of embassy, Dr. Lee, and also Dr. Salina. So I think today's lectures just want to give insight about how to use the big data analysis to forecast the pandemic, and also to help people in the world show how Taiwan used the digital contact tracing to trace the suspected infected disease contacting with already infected. So I think I start from my lectures, and let me have a slide first. Yeah. My name is Tony Hsiu-Hsi. I'm actually the Vice Dean and Professor of Epidemiology and Preventive Medicine. That's why I'm here, to share my experience about application of the big data technique to do the following, the five brief talk on predicting the pandemic, and also to predict epidemic curve, and also to show how to use the big data to do the digital contact tracing, and also show how to develop Taiwan models with high containment measurement on COVID-19, and to see how to monitor and to relieve the worry about the community-acquired infections. And finally, I show you how to use the big data, to evaluate effectiveness of contact measure. This is very helpful for easing the social distance. And I would like to remind all of you, actually the data is very limited, so far, even we have such kind of the pandemic. So you can see every day from different kind of data sources showing the confirmed case and the number of days and the recovery. So this is an update until the last week. You can see until so far, you have 7 million, the cases, and about the 400,000 case died. But the good news is, you see, you have 50% already recovered. That's why people start to think about how to ease, social distance to have a recovery of the economical crisis. And also you can see the death rate, the case-fatality rate also declined from February until the early June. So I mean, it tells us actually the pandemic, COVID-19 pandemic actually start to go down, but still global disease burdens, because still half of people not yet recovered, and you can see the following still have a newly confirmed case day by day, from different regions and countries. So this is actually the data we have we only have to predict. So from the January after the Wuhan outbreak, our team we have around about the 4 faculties and about the 3 to 4 research fellow and about the 10 PhD students to form a team to do one thing is every day they download the data from different multiple resource data like the Johns Hopkins the data, which is a main data set which always use for the following analysis. But of course, we sometimes validate this by using the another data sources from different sources. You can see from China, from the Wiki, and so on. So this is very important because when you do the analysis with big data and analytics, you have to have multiple data, sources, and sometimes the data is only in a snapshot. Means sometimes if you see the data, if you saw the data today, maybe they gone tomorrow. So you have to have a snapshot and catch up the data day by day. This is why the team devoted themselves to collect this database. Right now we have a database from different countries worldwide. That's why we can help the Taiwanese government, and they also Taiwanese the CDC centers, to monitor the trend of the pandemic, COVID-19 pandemic. And let me go down to detail about the very important concept. Why the COVID-19 is so contagious, transmission so rapidly, so rapid. You can see because when you see the COVID-19, they have a two part, and you have a clear concept is the first, the upper part mentioned about how do susceptible without infection persons, without infected persons are exposed to infected case, then they get infected, and these new COVID-19, not like the SARS. The SARS 17 years ago, although it's a new virus infections, but normally they infect people after the symptoms such as the fevers. But the new COVID-19 have a transmission ability before the pre-symptoms, and sometimes they have asymptomatical symptoms. So you see, the infected persons can be classified into the three types: symptomatical case, pre-symptomatical case, and also asymptomatical case, pre-symptomatical case, and the symptomatical case. So sometimes these models, if you have seen the in the journal, in the media, in also the video, you can see this is called the SEIR model, means susceptible, recovery, and infected. So this is the first part. We have to help, the policymakers to predict the COVID-19 pandemic. We are going to show to you how we use this model combination with the data to predict. But the COVID-19 cannot only rely on the SEIR model, cannot rely on only the infectious transmission model, because the COVID-19, you never know who is going to die from this disease, and who is not going to die, and who had the mild symptom and who had the severe symptom. So you have to understand the disease progression models from mild to to moderate with outpatient care, and sometimes with hospitalization care, then they can recover. And about 5% to 20%, depend on countries and depend on your critical care capacities. That's why this part is so important to look at. So for those countries without critical care capacities, the people sometimes has progressed from severe pneumonia to the ARDS. ARDS means a severe syndrome of SARS. Then they have a 0.5% ARDS die from COVID-19. So the COVID-19 is not only like infectious disease. The COVID-19 is also like the chronic disease with the progressions. So the Premier Chanson, the UK Premier Chanson, is a typical case, progress from mild to moderate and nearly to ICU with the ARDS, and they saved his life, by a margin. So this is a case. So because of that, I try to give the seminar starting from how can we combine these two models to predict infectious, the number of infected, and predict the days and also recovery. So in order to make everyone, understood with ease, I give you very, very simple concept about. Actually, the models is not difficult because the model actually predict the terminology called the basic reproductive numbers called unknown. An unknown has, is determined by contact and the transmission probability and also infection period. So the modeling, the technical, if you use very simple mathematical algebra, even the primary school student can calculate. If you have a high contact rate and high transmission probability and longer infection period, you will have one case produce the more next case. So for example, in Taiwan, people always wondering why we don't have a community-acquired infections. Even we have some imported case. We have some, the public gathering infected case. But why we don't have the community-acquired infection? Because you can see in Taiwan from Changhua, also from Changhua Christian Hospital case, you can see this case show per day the contact rate can be reduced to 20 because of the good border control, because of the good policy about quarantine and isolation, and also social distancing. So, for on average, you can only have per day, you can only for one person's contact with the peoples to infect, it's only about 20s. And again, from our Changhua Christian Hospital experience and also our national the data showing transmission probability is about just 0.007. So it's very low. And infection period, I mean, this is quite standard in the world, is about 5 days. So you can see you get about 0.77. And because 0.77 less than 1, if you have a less than 1, then you have no community-acquired infections. So compare with the foreign countries, generally speaking, for such countries with a large epidemic, you see they almost have a reproductive number about 2. So means if you have 1 case, you generate 2 cases, then 2 to 4, 4 to 8, and 8 to 6, 7. It's like the exponential growth. So that's why they have a very, very high transmission, like in New York, like the Italy, like the UK. They have a high contact rate and a high transmission probability. Even they have the same long the infection period. They produce, the high reproductive number. So people are very interested in looking at what is the effectiveness of the social distinctions. If you use a social distinction and a good border control and good isolation and quarantine, you see you reduce 50% contact rate. And if you have a personal protection like Taiwan, everyone to wear the facial mask, and everyone wash hands frequently, so you can see the transmission probability is almost about only half of the figures in the compare with foreign the country abroad. So this is a very simple concept. I'm going to speed up our lecture. Is once you know this, so you can know you can apply the modeling technique to make such things, to monitors by time trend by different regions. So you see, this is a case about, in addition to Taiwan, Australia have very high reproductive numbers. After the social distance control, they already, go down to less than 1. So this is a very good control, Australian and also like Korea. But for the Asian Africa, South Asian Africa, you see, and also South America, you see, there has a still outbreak here because even they have a downward trend, but you see the reproductive number still larger than 1. And Europe and also North America, even the closed one still have an outbreak. So that's why in the world, the global, the global figures show they still have a very high, pandemic in some regions. So that's why we have to, do this real-time, evaluation modeling. And this is the first part about the infectious disease predictions. And for the second part is about the disease progressions. So I mentioned earlier, this progression index is very important. So if you can have a low progression from hospitalization to ARDS, so you have a low case fatality. And this is, I help the government, you see, to do the international assessment by looking at the progression rate from, hospitalization to ARDS. So the higher this percentage, the higher the case fatalities. And you see Taiwan is here. There is a very, very low. So that means you cannot only have the infection control policies, you have to very good the critical care capacity preparation and also hospitalization preparations. So this is also shown. And you can also see using the models, we can also alert the government to see until the end of the June, how many cases we predict. So this is our team predict until the end of June. It's about close to 10 million cases, So that means about 2.5 million new case would occur, during these 2 weeks. So this is actually the curve. We also work together with our central government, CDC, to use this figure to monitor the time trend. And also sometimes we go down to predict this curve in different countries, in different regions. But time is limited. I just show you one case about New York. So you see, New York, we can predict not only about the infected case, but also pre-symptomatical, symptomatical, asymptomatical case. So you see, the New York case can tell us the symptomatical case account for 46%. But the pre-symptomatical case, at the time you have you have observations, the 43% is pre-symptomatical. They would go from pre-symptomatical to symptomatical, and about 10%, 11% asymptomatical. So WHO announced 2 days earlier, say asymptomatical is not infectious, but this is not quite right. That's why so many people argue with this. Asymptomatical still have transmission. According to our models, they have at least half of the transmissions compared with the symptomatical case. So you can see this is a predicted curve for COVID-19 New York. So we use these big data analytical combined with the modeling technical, combined with the data, to predict, the AV, to predict the epidemic, the curve for AV regions in order to do the real-time monitor, real-time assessment for monitor these COVID-19s. And there's another, the many applications, and you can also apply to other, the outbreak. I just show you another very interesting is about, the cruise ship. The cruise ship actually is Diamond Princess. It's very famous, you see. And you can also use this Diamond Princess to learn the epidemic curve here, because this is a closed cohort populations. So you can always follow this closed cohort to understand what is the COVID-19 natural process. So you see, this is the AP curve to show susceptible go down and the exposed and the infectious disease confirmed case occur, then after that they recover. So this is actually a very, very high contingency, proved by this cruise, the outbreak occurring on the cruise ship. And this is actually, I just show you, mathematician and our the PhD student use this differential equation in combination with analytical technicals to analyze, the reproductive numbers, and what the information they can convey. You see, not only to predict the curve, the curve grow up, but also sometimes you can use this curve to suggest when we have to evacuate these these peoples, and when you have to isolate these peoples, at the time they're already infected. So this is actually important message for providing the timely suggestion for surveillance. So, and also they can also predict if you have the containment measurement, what is the efficacy of reducing this curve? So this is actually in Japan, they only provide the policies about mid-February. After mid-February, you can see the curve actually go down. If they don't provide this, the epidemic curve show the even worse. So this is actually the main application of the prediction for closed cohort epidemic curve in the cruise ship, and it's very useful. And we also use to elucidate our Panshih-class, have had an outbreak, in April. So you see, the Panshih-class show the reproductive number is not so high. That's why we can understand why asymptomatic case with a high possibility of having transmission during their voyage, and until the early Aprils, they have a case infected by this asymptomatic case. They produce the 17 case before before they went off this the warship. So we also predict the case is very close to the curve. We already show you this. So this is one of the application learning from the Diamond process, then that Diamond Princess, and apply to our warship to predict the curve, and to also help our government to make a good decision on how to have surveillance of warship in using this case as a demonstrations. And the third one I want to share with you is a digital contact tracing, which is a so important part in this. So the Taiwan government this time combine the the immigration information and the police system and mobile phone and the mobile app, and also the sale message, and also the some of the CTT, and also electronic toll, and also the health insurance claim case, to do the quarantine isolation, and to have a very good reload and compliance from a participant, from the peoples, and also to do the digital contact tracing and surveillance, and by combining the medical service. So this is we call the big data for containment measures by making use of these data informations. So this is actually using the Changhua as an example. The Changhua actually to break through the conventional contact tracing only based on the questionnaire interview, and also risk assessment measures by using the CCTV and also health insurance card. You see, this is have a contact tracing with the police system to monitor whether they stay at home for isolations in order to go out for infecting other people. So they also use the geoposition measures to, to trace if people go out. So this is actually a very good system to show the digital contact traces. And because we have such kind of the planning in the beginning, so when the Diamond Princess, disembarking at the Keelung, the harbors, so we use the geoposition again to trace, the traveler, when they traveling, during the traveling route. And also after that, we sent all the possible contact with this traveler with a SAIL message and to alert them, to stay at home, and also alert them if they have symptoms, they go to hospital to do the RT-PCR test. And we also to monitor their disease, status by looking at whether they have a high, respiratory disease syndromes by combining the national health insurance data to monitor these people's the health disease status. So this is we already published in the medical the health the medical net research, and this is actually just give you a summary about the potential of the contact tracing. I already mentioned about from political system and also our the mobile system, geopolitical system, until the the transaction by credit card and so on. So, and this is actually show you the contact tracing route. You can see the use of geoposition to know the travel route, the travel route. So using this travel route, you can identify the possible contact, and then you can send the SAIL message, later on. So after this contact tracing route, and we identify about the 600,000 peoples, and the government sent about the message to alert them, as I mentioned before. So that's why they stay at home, and they all get the RT-PCR result with a negative, result. So means they haven't been infected. And also we follow the national health insurance to identify their disease status, and we found, these people actually has a low respiratory syndromes compared with the general population. So this is make we for sure that these people would not as a high become the risk group for contacting these people, even they probably asymptomatical. We don't think they are dangerous, So this is actually the very good experience of showing about how to combine this big data to the digital contact traces. And finally, I think I give you very short about the several slides to show you about because of the Taiwan models is very special. We don't have the outbreak, but we have the imported case. So you see, we have the 2 time points which are so important. One is the 7th February to stop to have border control for China and also Hong Kong and Macau, and also the about the 19th March, after we have so many imported cases from the European and also from the North America, the government decide to have a isolation from the border control. So you see the imported case already reduced from since April. So now we have a very few cases, but of course we have also have some indigenous case because of imported case. So we have to also monitor. How can we monitor? We also use the big data analysis by using this imported case and also this indigenous case, and using the also combined with the knowledge from SEIR models. So you can see we can also provide the government about the prediction curve, and also the 95%, the upper limit curve and the lower limit curve. The upper limit curve can tell you about whether you already beyond the threshold of epidemic. So we have 3 times nearly have a cumulative acquired, including Changhua, the taxi driver, the cases. But hopefully we have very good personal protections and also the social distance, so we don't have the community acquired. And this help the government to ensure, they have a very good, success. Have very good success in controlling the infection control. And this is another big data analysis by monitoring about the few case, but still in face of the imported case from the country abroad. Finally, I want to tell you, after the post-pandemic, every countries will like to evaluate when we want to ease social distance and lift the border controls. So we have to evaluate this border control and also mitigation plan, including social distance measure, and also personal prevention and also environmental sanitation. So you need the evaluation. So our big data analysis and our team, also help the government to evaluate, how do we show from there is no contact measurement. There is about isolation 15 and also the 50%, 70% and 90%. The higher the quality, the low the epidemic curve, then you can have a time to control this disease and to waiting for vaccines. So this is actually a case you can see if you have isolation 90 rather than 50, then even if you have a quality 19, you almost have no epidemic curve. And this is actually the model Taiwan already show you. But in different country, you need to evaluate by using this curve to see whether you have a chance of the second, epidemic curve. And this is so important about the resurgence of the epidemic curve after the pandemic. I mean, in Korea right now is a typical example. They have a resurgence, after the post-pandemic. Even they have about the release the quarantine, from 90 to 50, or from the isolation from 19 to 50. You will see they still have the epidemic curve to occur. So I just show you, the big data is very useful to help you to evaluate, see what is the reductions compared with no containment measure. And if you put some social distancing or some quarantine and isolations, and 50% and also 90%. So you see, this is a 50%. You still have epidemic curve, but for the 90%, you see, you don't have any epidemic curve. But don't forget, you have sacrifice about your ending. You have sacrifice of the economical activities, and you probably, is social distance to gain some benefit of the economical, activity. So this is a pros and cons, but you need to evaluate. And this is just to show you the Korea and Australia, because they have very, very strict, the social distance. So you see the Australian almost show no epidemic curve, but the Korea, you see, there is a still small epidemic curve, although it's not larger than the previous one, but still. So you need to, evaluate again to see whether they to prevent to become large epidemic curve like this. So the conclusion actually here is I just give you very short about the speech on if you can make use of big data, even data are limited, you can still help your health maker in any countries to facilitate to provide a timelines of the containing COVID-19 pandemics by different, the content measurement. And you can always look at the time trend, as I mentioned before. And then you have a time to prepare your healthcare and the critical care capacities in order to balance the epidemic curve, epidemic outbreak, and also the reviving, the reevaluation of the economical activities. And finally, I think, of course, doing such kind of the big data for evaluating the social distance measure or containment measure can help the government and also the stakeholders to have a good guidance for easing the social distance. So I think this is all I give you very brief about the application of big data for doing some evaluation on COVID-19 during the pandemic and also after pandemics. And we hope this is very helpful. And I think I leave time for Q&A, and I'm sorry I over time about 10 minutes, but I try my best to give this difficult picture, but try to be as simple as possible. Thank you so much.
Thank you very much. Thank you, Professor Chen. So we are going to open for QA. Before that, the first question I would like to ask Professor Chen is, because Taiwan just only has one national insurance system, so the national insurance system database preserve very comprehensive data, which can help the researchers like you to do the analysis and monitoring for an epidemic. But I think in most of Southeast Asia country, either the national insurance more diverse or lack of good system. So in this situation, the epidemic trace seems to become much complexity than Taiwan, I think. So do you have any suggestions or comments for rules of country?
Yeah, I think this is very good questions, and we are very fortunate because we have a nationwide, the health insurance data. So this time, when you go to the hospitals, you insert the national health insurance card, then the physician know your traveling history, so they can, they can immediately have contact tracings and to prevent the spread of the COVID-19. Unfortunately, I know in several countries you don't have such kind of system. So I still suggest, even you don't have such kind of information systems, you can do two things. The first thing is try to use the TOCC questionnaire. The TOCC questionnaire is so important for understand the traveling histories, understand the contact histories. So if you don't have such kind of those resources and the informations, you have to do the TOCC, the questionnaire to understand their exposed and also contact histories. And the second one, I do suggest some of the countries you can take this opportunity to develop the mobile app systems to do the digital contact tracings. It's not difficult. I have seen, in Malaysia, in Indonesia, in some Thai countries, you already have a very good app system. You can just put your app system to develop the alert system between the peoples, when they contact with a susceptible and when they have close contact with a suspected case, then can give you alert message. So this is also take this opportunity to turn the crisis into one of the opportunity to develop the AI, artificial intelligence systems, and which I think is very feasible. Yeah.
Yeah. Thank you, Professor Chen. So we are very lucky. We also have Dr. Soawapak, Dr. Chu, and she joined us last week. So I'm very appreciative she spent her time to join us today. And she's the Director of Office of International Cooperation, the Department of Disease Control of Thailand. So I know in Thailand, you have 3 insurance system schemes. So could you please share how do integrated the three systems data and apply for the epidemic monitoring and forecast. What is the most challenge to confirm three systems data to be accurate?
Hello, you can
Hi,
hear.
see you again.
Hi, see you again.
Thank
Okay,
you
good
so much.
afternoon. Yeah, good afternoon, everyone. It's nice to see you again. And for in there, you asked about in the how we can use like the insurance data from in the T database, it's like social welfare, social security, and like UHC, right? To combine and make it into like a forecast and predict the trend of the disease. Okay, in Thailand, when we predict the disease, the trend, we are using the database from our national surveillance system. The national surveillance system, the source of this database is from the hospital-based surveillance. That's meaning our case that report into the system. Most of them, the source of information from the hospital base. And that's we call in the passive surveillance system. But as you know that in the COVID-19, it is emerged. That's meaning that we cannot use like a routine passive surveillance, right? Because in they just emerge. And in Thailand, we use in the compulsory. We have in the law enforcement that we call in the Communicable Disease Act. That's meaning and we have like a national committee or national communicable disease committee to identify, okay, this is COVID-19. We identify this COVID-19 infection, it is like a dangerous disease. When the dangerous disease it is proposed into our regulation in the law enforcement, that means we ask all surveillance officers, all laboratory technicians on the people who have detected within the COVID-19 infection. They have to report this case. This can be the suspected case, and we have the definition that is the patient under investigation. It don't need to be like a confirmed, just like okay, when you are suspecting some case, you have to report with us within 3 hours. That's meaning within the law enforcement, we can encourage the people, we can mandate the people to report the disease within 3 hours. That means we try to increase the rapid detection of the COVID-19. So when all the healthcare facility, okay, when they report to our database system, that means we have like a central database that collect information from the COVID-19 infection, just the surveillance database. When they collect it, we have the team that we call in the situation awareness team. They gather all the data. It is also just not only from the hospital-based surveillance, but we have another channel that we call the event-based surveillance. Event-based surveillance is from in the community, and they can detect any news or any abnormal event, and it in the from in the ILI system, right? Right, we combine all the data together, and then this team will analyze. And when they analyze, they submit the daily report to our another task force. That this task force is under the infrastructure of the EOC of Thailand. This task force we call the strategic plan. This strategic plan, when they receive the report, and you can imagine that in the database, when we analyze, we have to clean, we have to understand the nature of the disease, and sometimes we have the different model to predict it. This strategic plan will synthesize, will consider, and make it in the unified database. And then when we get in like the chart report, okay, what in the trend and what can be in decrease and or in the increase of in the case in the near future or in the next 3 months. They will report this result to in the upper level. That's we call the National Communicable Disease Committee. Committee will analyze this and propose the policy option to our minister. Okay, you can see that in the there's not only one model can do all the things, but we need a lot of opinion and unify those results and send the report back to our policymaker to make a decision. Okay, this is kind of what we use is for the predict and the forecast in the COVID-19 infection in Thailand. Okay, thank you.
Yeah, thank you so much. I guess
sure.
very short feedback to this is so good about actually hospital with a passive surveillance system and also community active surveillance system, and that's why actually I have already analyzed the Thai data. We also have some assessment. I mean that's why you have already control in the Thai data. I think the reproductive number nowadays is less than 1, which I already know that. Yeah, that's a very good policy.
Thank you very much. I think in Taiwan, that the university works very closely with the government, like CDC or DDC. But I don't know in Thailand what's the situation. So today we have 2 doctors from Mahidol University, also from Walailak University. And the first I would like to ask the Walailak University, Dr. Udusek, professor. She's the director of Research Institute for Health Science of Walailak University. Yeah. So could you please share in Thailand how governments like DDC or Ministry of Public Health works with a university like Walailak University to use or to develop different tools or models to monitor the epidemic and give the suggestion to the government? What is the challenges?
Okay, Udongsak here. Greeting from Walailak University. For my experience and also experience from my friend from who working on another university. Actually, you can like you heard from Dr. Soawapak that our system is actually very centralized. So, but if that province, if that part of the country that you work with, and there is like a lot of cases in that province, so there are some collaboration between the provincial office, the provincial health office with the university. For our university, for the Walailak University, actually, I myself have been have a contact from my friend working in Phuket, and then I do some simple prediction for them for Phuket province. At this, when they start having the epidemic in Phuket, so that is my contribution to that part of Phuket is not very far from Nakhon Si Thammarat, and we are actually in the same health region in Thailand. And also another of my friend who work in Songkhla. Songkhla is the province that have some border with Malaysia, and the situation there is more serious. My friend in Changhua Christian Hospital work closely with the Songkhla provincial office. So, but in Nakhon Si Thammarat, because our province is less affected by the COVID-19. Like we have only 11 cases, and then I think we have almost more than case, no reported case here in Nakhon Si Thammarat. So in Nakhon Si Thammarat, I think only the health officer dealing with the COVID-19 epidemic. But like I contribute to Phuket epidemic containment, and like another of my friend also contribute to the Songkhla province. So that is the way we collaborate. And at the national level, actually, under the ministry, under the I don't know the name, but it's like kind of higher education ministry. I don't know exactly what its name, but they have issued a research grant that every researcher from the university can apply for the grant, but you need to like have the proposal, and then you submit to them to work on COVID-19. But you need some collaboration with the health officer to get the data. They provide some public data, and then you can get from the Department of Disease Control website, but the detail is not very much. Like you have some like 3 or 4 demographic variable, and then you can do some epidemic curve, but the detail information is not there in the public. So in Thailand, if you want to do this kind of research, you need to have some connection with the public health officer. Yeah, but now I think the government try to use some more big data, so they just around 2 weeks ago to the data, and then the government, I think they will use as big data to do some contact tracing. Okay, I think that is all from me.
Thank you. And I think we have Rama Hospital from the Mahidol University. Dr. Xiao Mengxing. Yeah, maybe you can share your experience.
Hi.
Yeah.
Can you hear me?
Yeah, sure. Yeah, please.
Yeah. Actually, I'm not. We are not working. I personally is not working on the public health, but I can share some research part that Rama has been doing with together with Faculty of Science, Mahidol University. So we started from developing the test kit, and we have commercialized the test kit by using saliva to test the COVID-19, the SARS-CoV-2 virus. So this part was collaborated between the Faculty of Science and Reproductive Hospital. And the second one is that we got donation from one of the company in Taiwan. It's called Bionet, Xunlian Jituan. So they donated the mesenchymal stem cells derived from umbilical cord. And these mesenchymal stem cells, they were approved by Taiwan FDA, can treat the patients with severe stress lung inflammations. So we got donation from this company, and luckily the pandemic is not that bad in Thailand, so we haven't been able to get approval from Thailand FDA and treat our patient. But I think we are on the way that we will try to get it approved by Thai government, and we can do some research and maybe clinical trials after we got all the approval from Thai government. And the third part is also the collaborations between Faculty of Science and Reproductive Hospital, is that we have our own clone of potential vaccines, and it's the protein vaccines that is under development. So the three part of the main research aspect mostly collaborate between Faculty of Science and Reproductive Hospital. And apart from the research, I want to make some comments that I think Thai government is doing very well, and is the strategies and policies and regulations are pretty much similar to what Taiwan government is doing. Like, they don't really test everyone, but they keep their eyes on people who have to be quarantined. They probably are from repatriation flight, and they have the system they called regional health volunteers. In the countryside, they have these volunteers. They will visit you if you have to be quarantined. So this is the question that I was asked by Taiwan friend, whether Thai government has the system in order to like watch people whether they really quarantine well at home or not. So this is the system that I got amazed. They have the health volunteers in every single district and small countryside regions. So I think that's why Thailand is doing very well. We only have a little bit more than 3,000 confirmed cases. We are free from local transmission for almost 2 weeks now. And we are going to be, today we have 0 confirmed as well. So I think that's the research part, and also the government and the people in Thailand, they cooperate very well to combat this pandemic situation in Thailand. This is my comment. Thank you.
Thank you, Mongzi. Yeah, she's my good friend.
Nina.
Yes, Professor. Yeah.
Let me answer the question you asked about. You use a regional volunteer, to monitor these the people keep quarantine. And I explained in my slide, in the local government, people use. We use the police system, in combination of geopolitical measures to actually monitor, the people who's they are required for isolation and quarantine. So that's very efficient. That's why we have very quick, have a very quick way of reducing the contact. The contact with the infected case. So I think this is I want to reply to you. So I know but the regional volunteer is not bad. But there's you need to spend much effort, to organize this teamwork, and sometimes you also need to develop some personal, protective equipment for these people when they do the job. So I think I think we still encourage in the countries, if you have some geopolitical data set, you can use that, because it's very, very, very efficient. This is my suggestion.
Actually, the health volunteer system in Thailand has been developed for a long time, not only for the COVID-19 pandemic. So they have these health volunteers many years, and they train, because they are countryside, they need people to train people how to drink clean water, something like that. So this system is already established well in Thailand, and they just re-educated the volunteers of the knowledge of COVID-19, and also assign them to watch and help the people who have to be quarantined. So actually, my husband is Thai, and he has been in this health volunteer system when he was young. So I think it's pretty good, an amazing system of Thailand. But of course, using big data is much more efficient in managing the system. And of course, yes. Thank you.
Thank you, Professor Surin from Walailak University. We can hear you. The signal. Yeah, please.
Okay. Just obviously, and he already partly answered my question, I guess. But you could comment further on the data system, collection system in Thailand, or into that, because I'm not in the health environment, but I know and my impression is that in Thailand it's always a bit problematic from different sources. So I'm not sure whether Prof. Chen would be kind enough to comment further. Prof. Chen?
Professor, the signal is very weak. I don't know what's happened the internet.
I see. So probably it's a problem.
But I guess your question, you wanted me to comment about she already explained about how government have a centralized data set by using the data report from hospital and also event data from the communities.
Mm-hmm.
Yeah, I think this is a good in the beginning of the pandemicals, because the government. I will also suggest the country in Africa, in South America, right now I want them to have a centralized data set from the beginning of the pandemic, because if you don't do that, the system if you use a decentralized, measures, it will become very, very confused and also will be in chaos, But I would like to suggest, that's why I want to ask all of you from the Thailand colleague, and what do you think about the post-pandemicals when your government want to ease the social distance? How did you do that? In Taiwan, we start to think about how to have a decentralized policy, even to have the data management by assign the regional hospital or the hospital in different regions. They can do it independently to monitor the contact persons in the future. I think the Changhua Hospital haven't received yet a message, but this is actually going to be a government policies to go from a centralized policy to decentralized policy in order to to ease the pressure from the economical the reopening. So I would like to ask you about the comment. So I also want to know your opinion from your government or from your professor in Thai. Yeah.
Who can answer Professor Chen's question? Yeah. Yeah, from Dr. Ju. Could you answer?
Okay, yeah. Actually, we quite believe that in the COVID-19, it can be like an endemic disease in Thailand, but also in the other country as well. As I told you at the beginning, that we have in the national surveillance system that we call the system is just like we have in the exiting system, and now in the surveillance communicable disease like 57 communicable disease, and I think for the future we will plan to integrate like COVID-19 into our routine system. That means in all hospitals in Thailand or in the health facility, they can use that platform of our routine system to report any suspected of the COVID-19. It's just like an influenza or in the other respiratory disease that we provide the platform that our hospital can report the disease. So this is the future that we plan for doing that. But for the COVID-19, the case definition, how to report the COVID-19 into the surveillance system. The case definition, I think the most part we need laboratory result to help us to confirm like a COVID-19 infection. So the challenge that we have to do in the future when we integrate the COVID-19 into our routine surveillance system is how to integrate database from the laboratory system and the surveillance system into the one system, and it's like the linkage between two database, and so we can use the data of the surveillance from the surveillance database into in the most benefit for predict for use for in the epidemiological report. I think this is the important that how we can link it the two systems together.
Yeah, thank you very much.
Yeah.
I think the test is so important. This is actually it's not topical today, but I totally agree with you. If possible, even in Taiwan, actually today in Changhua we start a zero surveillance program in Changhua to test whether they have an antibody. To see the past infections. And I would suggest that if possible for some hospital and for some area with a high infection area compared with one control area, you can also do the zero surveillance in order to understand the past infection. This is so important because you can also know the immunity status of the populations in order to develop the vaccine. I had heard, it's so good, you also have a vaccine policy, So I would suggest, in the post-pandemic period, not only in the big data technical, but the information from test, either antibody, or the antigens, it's so important to validate, the data you report from hospital or from from the administration. That's very good thinking. Yeah.
Thank you, Professor Chen. Sorry, our time is up. I'm so sorry that I don't have the chance to give our participants the ask question like from Indonesia. So sorry for that. Maybe next time. So thank you very much for all of our friends from different countries to join us today's online seminar. Hope to see you next time. Bye.
Thank you.